really do it. And not like lab, don't recap your needles. Makes me crazy. Alright, so first thing I do is I visually inspect and look for symmetry and cephalic, so normal cephalic size. So it means that her head is appropriate or appropriate size for her body. You might laugh, but I've taken care of some kids where you're like, whoa, hey Melon. So, and then the next thing I'm gonna do is I'm gonna tell me if anything hurts. And I'm gonna press over the sinuses, and then I'm just gonna palpate the scalp. And before I did that, I do this without thinking about it. I always look right above the ears for anything that looks like lint. If I see anything that looks like lint, I go put my gloves on, okay? Because there's probably some creepy crawlers up there, okay? And if I think there's creepy crawlers up there, I actually will look for them, okay? So, because I want to be able to verify that they are there.
I'm itchy all day.
I'm glad you don't have it, okay? And then I'm gonna palpate right back here, right there, because there's a group of lymph nodes right there. If you feel them, then let me know, okay? But you should not feel any lymph nodes back there. Then I'm gonna follow my hands back behind the ears for lymph nodes and right in front of the ear for lymph nodes. And then the sternocleidomastoid muscle, this one right here, there's a group of lymph nodes right behind it and right in front of it. So you're just gonna palpate. Now, I'm not going over the carotid artery and rubbing, okay? Because that's not nice. I would not like that.
Not both at the same time.
Okay. So then I just palpated for lymph nodes and I did that right underneath the chin too. Okay? So that's my H. So I have my H-E-E-N-T. So that's what I'm doing right now. So that's my H. Now I'm gonna move to my eyes. Okay. In the chart, there's gonna be a spot where you can chart perla, but guess what? You're not doing accommodation. If you've been taught that this is accommodation, look at my finger. You see how she goes cross-eyed? That's called convergence. It is not accommodation. So come here. Now, somebody come over here so you can see her pupils. Okay. See that exit sign all the way down there? Mm-hmm. Look at it. Now look at my finger. Now look at the exit sign. And now look at my finger. You notice that when she looks at my finger, her pupils get smaller. And when she looks at the exit sign all the way down there, her pupils get bigger. Can you do this exam in one of those patient rooms?
No.
No. So you can't do accommodation unless you bring your patient out into the hallway. So don't chart it. Okay? Under the neuro norms, the first neurological section, it will say that you can chart pupils are equal, round, and reactive. And then there's another spot that says pupils equal, round, and reactive to light with accommodation. And we're not checking accommodation, so don't. I have never in my life had to check accommodation. But I've been taught in paramedic school and in nursing school the wrong way to check it. Yep. So in nurse practitioner schools, when I actually learned what accommodation is, it's accommodating for distance is what it is, not converging, okay? Our brains work by distance, by convergence, right? This is how our brains know how far something is by how we have to converge our pupils. But it accommodates for vision distance differently, okay? All right, I am not gonna shine this light on that, but I'm gonna demonstrate it because this is stupid, right? Okay, so when I check pupillary response to light, what I'm gonna do is I'm gonna check, so where I'm pointing my finger is where my eyes are looking, okay? This is called direct pupillary response. and then consensual pupillary response. And then I do the same thing over here. Direct, consensual. Okay? Now I didn't shine this at her because, well, it's stupid, right? But that's what you're checking. So always direct and then consensual. Okay? So you're actually shining the light 4 times, twice in each eye. But you're looking at different eyes each time. Okay? And then the next thing I'm going to do is I'm going to do my 6 cardinal fields of gaze. Okay? Now, what I want to point out is if your finger is this close to her face, it's uncomfortable. You want to be about 2 foot, about 18 to 24 inches away from the face. And then what you're going to do is you're going to go to the side, nice and slow. And you see how nice and smooth her irises move back and forth? That's what you want to see. If you see like a jerkiness like that, that is called nystagmus, and that's what the police officer is looking for. Okay, so you want that nice smooth motion. Okay, and so that's back and forth. If I go too fast, I'm not going to see any nystagmus. And then I need to check my oblique muscles. So up to the corner, and then across the top, and then down to the bottom, and then across, and then back to center. Okay, that's the 6 cardinal fields of gaze. So, and that checks 2 cranial nerves, which you'll be studying next semester. So if you get it in your habit, in your brain to do it now, then you'll be ahead of the game, right? Okay, so that's my eyes. There are a few more things we could check with the eyes, but we're not there yet. Okay. All right, so now I'm ready to check my ears. So what I do with the ears is I pull up. On an adult, on a child, I pull down. Okay. What happens if she has otitis externa? That will hurt. So that will give me an indication that she may have swimmer's ear. And then I look in the ear, and I look above the ear, behind the ear, and I move this so I can see the top of the ear, right there, because that's where a lot of skin breakdown happens, especially in the day of Corona when we're all wearing masks all the time. And then same thing over here. So that's my ears. You could do a gross auditory exam where you just whisper like 2 things, apple, box, and you have them repeat it, and then do the same thing on the other side. I don't do that unless I'm dealing with like a child patient or something that was in a car accident or some loud noise.
Probably good plan.
Typically, like on this floor,
We'll see you
I would
soon.
never do that exam. That's the other thing I want to point out, is if you practice all of this now, you can break it down into small pieces later. And when I go into a patient's room, I don't always do my full assessment at that time. I usually break it down because they don't like me that much, I don't like them that much, so we don't really want to spend, a good 40 minutes together. All right, so next is my nose. And then what I do is I have my patient lean their head backwards, and then I lift up and I look straight in the nose, and I look to make sure to see that the septum is midline, or if it's deviated right or left. And then I also want the septum to be nice beefy red. And then when I'm looking back, straight back at this angle, right about here is where I see that medial turbinate, which is part of the nasal cavity. You can get information based on that, like if it's a dusky grayish color, it means they probably have allergies. It should be pale pink though, okay? If it's bright red, it's probably an infection. So it could be a pharyngitis or something that has moved up into the nasal cavity.
And if they do cocaine, you see sores, right?
If they snort coke or anything else, you'll probably see sores along the septum. You may actually see the septum be pale instead of beefy red. You may actually see that the septum's gone too. So, yep. Then we go open up, say ah. And I actually want them to say ah, because what happens when you open up and say ah is that soft palate raises, and that uvula should stay midline. If it doesn't, sometimes it will point to one side or the other, and that can indicate tonsillitis, or it could indicate a stroke. So that's part of my stroke exam too. Hold the pizza box up, open up and say ah, okay? I'm also looking to see if the buccal or buccal, depends on where you come from, how you pronounce it, mucosa is moist. One of the early indicators of dehydration is the mucosa of the oral pharynx or oral area becoming less moist. And then also that it should be pale pink, and the gums should be pale pink, and then you shouldn't see any sores in the mouth. Okay, if they have dentures, this is the time to take those out and explore underneath to make sure that there's no wounds. All right, so that's my HEENT. So now I'm ready to move on down to the chest, and I'm gonna start out with my cardiac. I always start cardiac before I start respiratory. I don't know why, it doesn't matter. If you wanna go respiratory then cardiac, just so long as you remember to listen to everything.
So my first semester here, they didn't learn eighth man.
I know.
They didn't?
No, they didn't do 8th man their first semester. They did 4 spots, not 5. I don't know, what did you guys do? What was it, mnemonic?
All physicians take money.
That doesn't include Erbs Point. We're gonna do 5 instead of 4. Okay, so I start right here with my carotids though. Say, take a deep breath, hold it, breathe. That's all the time I need to listen to the carotid artery. Okay, and I'm listening for like a swoosh noise, a bruit is what it's called, but it's like a whoosh. It's like a blowing noise. And I would not have even listened to this on someone Shannon's age. If they're 50 plus, then I would listen. Okay, unless she said, "Oh, I have a history of, you know, a murmur or a valve replacement or something like that," then I'll listen. Okay, then I'm gonna listen to my 8th command. So, A is
The second intercostal space.
that's where I'm at.
On the
What's
right
the
side.
A stand for? Nope.
Atrial.
Or no. Aortic.
Aortic.
Remember, these are the valves.
I always think atrial.
So, aortic, then pulmonic, so second intercostal space, right, and then second intercostal space, left. Pulmonic. That's ape. E, Erbs Point. Erbs Point is a good one because you can hear mitral stenosis well here. Okay? Then tricuspid and mitral or apical. Okay? And that is this is the underwear spot. This is where you have to stick your stethoscope under the underwear. Okay, so that's your spots for your heart. Okay? Now, a lot of students don't realize you need to listen to each one of those spots for at least 15 seconds. If you don't, then you're not gonna pick up extra beats or irregularity. If I only listen for 2 beat cycles, like love dub, I don't know that it went love dub, love dub, right? So listen a little bit longer than what you typically have been. Okay, now let's go posterior. Okay, now textbook. There are 16 spots on the back that you can listen to. 16. I have never done it, except for in nursing school and in NP school, and when I demo this. Okay? There are 6 spots on the post, or there are 6 spots you have to listen to though, okay? Like I said, there's 16 spots you can listen to, but there's 6 you have to listen to. I'm gonna show you the 6 that you have to listen to. First, just above the scapula, both sides. You're comparing sides. Just below the scapula, both sides, okay? Then 6th intercostal space, this side, 6th intercostal space, this side, okay? How many lobes do we have over here? 3. Guess what? This is the only place we can hear that middle lobe. So you have to listen there, okay? That middle lobe is also the one that if you're gonna have aspiration pneumonia, which is a very popular pneumonia to have, I'm not saying it's a good one to have, but that's where it's gonna go, is that middle lobe, okay? So you have to listen to those spots, okay? If you have a patient up here that's in a turtle shell, you're not gonna get to listen to those. You're gonna be lucky to get here and here, but you always wanna make sure you do get to the bases, okay? Because that's where all that fluid settles. If you're a patient up here and you're at risk for pneumonia, it's gonna be in the bases, unless it's aspiration. Okay, now, do you think this is a universal size for a stethoscope, adult size? Have you ever seen one other than an oblong one that was a different size? Because it's a universal size. This is a measurement. So when I am listening for my 16 spots, guess how far down I come? Yep. And then down, and over, and down, and then over, and down, and then over. And now guess what? I'm below the scapula. Now it's down, over, 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 middle, middle. 16, right? There's 4 here, 4 here, 4 there, and 4 there. So that's 16. Good thing to know. Like if you're working in Alaska and you're the only nurse and there's no x-ray, you may have to listen to all 6 of these because you think your patient has pneumonia. And so you'll do a test that's called like egophony or whisper pectoriloquy. Egophony is like, say E, and then just say E, and then you listen. And when you hit that spot of consolidation, it'll go from being an ah sound when you're listening to an actual E sound. Or you do whisper pectoriloquy, which is say 99, say 99s. And then when you hear the word 99, that means that you have found their pneumonia. Okay? That's a little on the advanced side of where we're going, but I just wanted you to know that that's why there's 16. Okay, and then there's 4 lateral, armpit to armpit, and then that 6th intercostal space. That 6th intercostal space is an important place to remember, and it is easy to find by the breast fold. So male, female, all have the same breast fold, right? And that's that 6th intercostal space. Like if you work emergency, you want to know that because if they have a tension pneumothorax over here, they're going to stick a needle right there and let that lung down. Okay, yeah, plus it's, good to be able to be, this is where I listen, okay? All right, and then back to the front. And
check
so-
symmetry.
What's that?
You check the symmetry.
No, you're gonna pick up on that visually. So, you always visually check for symmetry. I don't make you do the, chest excursion. Or
Chest
yeah,
expansion.
it's actually called chest excursion.
Oh, okay.
Yeah, but no, that's kind of a pain. I will have you do this though. So, do you have any back pain, any urinary issues? Okay, good. I always ask that before I do this. And this is called CVA tenderness, costal vertebral angle tenderness. Basically, you're tapping over the kidneys to see if there's any pain. So if they have a UTI or pyelonephritis, we would be peeling Shannon off the ceiling right now, because that would hurt like crazy. Right, turn back around. Lung sounds in the front. So you can actually auscultate lung sounds just above the clavicle. I've never had very good success with that, so I always listen underneath the clavicle on both sides. And then where my heart sounds were, here and here, and then there, and then there, and there. So there's actually 8 spots on the anterior chest that we can listen to lung sounds. Males and females, there's a lot of tissue on the chest to listen to hear anything. So the best place to auscultate is posterior. So if I can listen to someone's back, I don't ever even listen to their front. And the only thing I listen to on the front is the heart, and that's because it's on front. Okay? But the best place to listen is on the back. So, alright, so that's my chest. Now I'm gonna go to my abdomen. Abdomen, exposure from the xiphoid process to the symphysis pubis has to be exposed. If it's not exposed, you're not inspecting the abdomen. Okay, I'm gonna look for any abnormal movement in the abdomen. If I can see peristalsia happening, that's abnormal. Okay. If I see pulse, depending if the patient is laying supine and they're thin, yeah, I'll probably see a pulse. But if they're not any of those things, then I shouldn't see a pulse. Okay. And if I do, I'm not going to push there. Okay. All right. Some textbooks say that listen. So visually, look, listen, feel for the abdomen. Okay. So some textbooks say to listen in the order that the bowels move, but it doesn't really matter as long as you listen in all 4 quadrants. Okay. I listen until I hear noise, because I don't care if Shannon has hyperactive, hypoactive bowel sounds or normal active bowel sounds, because those things don't mean anything to me. And maybe she's hungry, so she has hyperactive bowel sounds, or maybe she has a bowel obstruction, so she has hyperactive bowel sounds. They don't mean anything. They don't correlate to anything, is what I'm saying. The only thing that correlates to anything is absent bowel sounds. Okay? Absent bowel sounds are bad unless you just came back from surgery, and then we kind of expect it. So when I get a patient back from surgery, I don't listen to their bowel sounds for about an hour and a half, because I don't want to spend 20 minutes doing this. Because you gotta listen for 5 minutes in each quadrant before you can say absent. And I don't got 20 minutes to do that. Okay? So I waited about an hour and a half, and I should have at least hypoactive bowel sounds, right? And if I don't, now I'm concerned. Okay? I'm gonna be doing stuff to try to rustle up those bowels and get them awake. All right, then I do palpation. Now, for palpation, I would say, is there anywhere in your abdomen that hurts? Okay, if there is, that's the part that gets palpated last. Okay, because if it was here that hurts and I push there first, now guess what? Everywhere hurts. Okay, and that's not going to give me an accurate exam. So then I just lightly palpate the abdominal wall, and I'm just really feeling to see if there's anything in that subcutaneous space that's hard. So if they had a hernia or they have a tumor or a mass, I'll feel that, okay? And then sometimes I'll push on the umbilicus and have them raise their head and cough. And if I feel something come up and tap me in the hand, that's an umbilical hernia, which is very common actually. Usually doesn't have any medical treatment or need to be treated, as long as it doesn't go tap and stay there. And then we could have incarceration of that hernia, okay? All right. If I suspect urinary retention, this is also when I will push down on the bladder, okay? Because if I suspect urinary retention, really what I'm gonna do is get a bladder scanner and check, but you can push on the bladder, and if they have sudden urgency, that means they have urinary retention. So, okay. Then I'm gonna move to my extremities, and I always start with my skin turgor right here. Okay, if you've ever skin turgored an older adult on their hand, you can come back next week and it's still tented. Okay, but it didn't really give you any indication of their hydration status. Okay, so that's why I do up here. Even on the older adults, if they have an actual hydration issue, you'll see some tenting there. Okay. Then I'm going to go to my pulses.
Mr. Outer.
And I feel both my radial pulses at the same time. Okay. On a pediatric patient, I'll check a brachial pulse, but not on an adult patient unless they don't have this part. You know, if this part's not here, then I'll check up here. Okay. And sometimes that happens. And then I check my capillary refill. Okay. If they have painted nails or no fingers, you can check the capillary refill right here. So you see how that blanches and then refills instantly? That's capillary refill as well. And you can go up the arm too and check it. Then I check for edema. And now I'm going to do my strengths because I'm still in the upper extremity. I'm going to go shrug. Okay. This, believe it or not, is actually checking one of the cranial nerves as well. And then I say, hold your arms out like this, push against my hands. Squeeze my fingers. See how easy that was to check your strength without giving multiple commands? Push against my hands. The easiest way to do it. I do the same thing with the feet and legs. Push against my hands. I put my hands on top of the foot, and then under the foot, and then on the sides of the legs, and on the insides of the legs. So then I'm going to come down to the leg, and I always feel right behind the knee for tenderness. Does it hurt at all? And then for warmth, and then I come down the calf for the same thing, and I give a little bit of a squeeze on the calf muscle. Not a big squeeze, it's a little one. Then I check my dorsalis pedis pulse or pedal pulse, and then my tibial pulse, posterior tibialis, okay, on both sides. And I actually check it bilaterally at the same time. Then I check for edema, and if I have edema, I go up the leg until it stops, because I want to know how far up that edema goes. If I go all the way to the hip, that's whole leg edema, right? But typically it will stop somewhere below the knee in a lot of patients. The reason I do that is because if I know this and I'm treating them for fluid overload or heart failure or something, I can tell whether it's getting better or worse, because it will travel up the leg if it's getting worse. And it will stay the same or go down the leg if it's getting better, okay? Okay. Questions? Okay, so that's my physical assessment. All of my history stuff, like do you have change in vision, change in smell, headaches, all that stuff, I do that way at the beginning. The other thing I want you guys to try to get in the habit of doing, since you have 2 patients, right, at max, is when you go in the room to introduce yourself, go sit down. Unless you think the patient's going to get up and beat you up. Then don't do that, because that's